Hello, I'm Dr. Robert Kaufmann. We're about to go beyond the Terminus. Sodium hypochlorite is pretty much the standard irrigating solution for endodontics and has been that way for more than 75 years. There are some differing opinions as to the best concentration to use in treating cases. Most literature has shown that North American endodontists tend to use higher concentrations in the 3 to 5.5% range, depending on the product. Our European colleagues have historically used lower concentrations in the 1% range. Regardless of what percentage you use, it's important to remember that the purpose of the solution is twofold. There are 3 types of reactions that contribute to its effectiveness. The first type of reaction is called the saponification reaction, and it is the dissolution of organic tissue when sodium hypochlorite degrades fatty acids and lipids, resulting in soap and glycerol. The second reaction is called the amino acid neutralization reaction. Sodium hypochlorite neutralizes amino acids, forming water and a salt. The high pH of the sodium hydroxide interferes with the cytoplasmic membrane integrity. The third reaction is chloramination reaction. Hypochlorous acid, a substance present in sodium hypochlorite solution, when in contact with organic tissue, acts as a solvent, releases chlorine that combines with the protein amino acid group and creates chloramines. So there's our hypochlorous acid, which is the key element. The chloramination reaction interferes with cellular metabolism, and oxidation provokes irreversible bacterial enzymatic inhibition, replacing hydrogen with chlorine. The other important factor is that Clorox or Javix is shipped normally at a very high pH. So we can see from this diagram that the amount of hypochlorous acid content present in sodium hypochlorite is optimized not at the pH that is shipped to us in Clorox or Javix, which is approximately a pH of 11, but actually the highest level of hypochlorous acid, therefore the highest bactericidal activity, is achieved when optimal concentration of hypochlorous acid is present at roughly pH 4.5 or 5. So how do we compensate for this when we are working with patients? Well, what we do is, in our office, is we use regular sodium hypochlorite for our cleaning and shaping for the solvency, its ability to remove and dissolve tissue. And then we use a modified formula for the final bactericidal rinse. That modified formula allows us to raise the amount of hypochlorous acid and increases the available HOCl, and it lowers the toxicity because we've diluted the solution substantially. What's the formula? 50 milliliters of distilled water, 0.5 millimeters of sodium hypochlorite, 0.5 millimeters of acetic acid, which you can use white vinegar, which is roughly anywhere from 5 to 12% acetic acid. And we mix it fresh for each treatment, though I understand it works. It can stay for probably a couple of weeks if it's mixed like that. I'd like to thank Dr. Gary Carr for alerting me to this and for giving us the formula and for explaining why this works so well. Some clinicians have advocated heating the sodium hypochlorite solution. I used to do this in my practice, placing the irrigant in a container that was used with a coffee cup warmer kind of thing, where you put a coffee cup and on a heating element. Problem with this is by the time you load the syringe and insert it into the canal, you're really not raising the solution much above body temperature. Heating the sodium hypochlorite excessively or leaving it warming all day can also cause the solution to break down. I moved on to a dedicated powered irrigating pump syringe device with multiple solutions and heated hose lines. There were problems with crystallization of the solutions, hypochlorite in the machines, corrosiveness of the solutions, and breakdown of those delivery systems. They leaked a lot, and I eventually returned them. As bad as a small bit of extrusion of hypochlorite may be, and that should never happen, extruding a heated version of hypochlorite can cause even more severe pain and even more severe tissue damage. For me, it simply wasn't worth it. Part of the problem with endo irrigation is the limited volume of the canals themselves. Studies generally agree that it's turnover of the solutions and copious irrigation that seems to work best. So volume and time are important factors when irrigating solutions are used in canals. As the canal shapes get smaller, this becomes even more challenging. With financial pressures and greater efficiency of rotary instruments, There is a tendency to want to do these cases fast. We must understand that for irrigants to work properly, they have to be used in a manner that takes advantage of both their tissue solvent and antibacterial properties. Both are directly related to the time of action. So don't be in a hurry to finish the case. In situations where the canals are difficult to negotiate, or you feel that you may have inadequately cleaned the canal, close the case with calcium hydroxide and return to it at a later time. In clinical practice, I continue to use my standard irrigation protocol, but I use this pH-lowered sodium hypochlorite version as a final antibacterial rinse. The initial higher concentrations are used for their tissue solvent action, and the second solution is used when non-vital or infected cases are present. Whenever irrigating solutions are used, the most important thing to remember is to keep the needle moving in and out of the canal with a rapid movement. Never lock it in the canal or insert it without this. As my mentor, Dr. Schilder, used to say, it's eject, not inject. For vital cases, I'm currently using this irrigation sequence. Sodium hypochlorite 6%, followed by EDTA at 17%, then back to sodium hypochlorite for 6%, and a final rinse with ethyl alcohol to dry the canal. In multi-appointment cases, calcium hydroxide is applied to the canals with a syringe and moved to the apex with the use of an endo activator. We confirm calcium hydroxide placement with a radiographic image. For non-vital cases, I use sodium hypochlorite 6%, same EDTA 17%. I then use an acidified dilute sodium hypochlorite, which we called N-mix, that's just the name we gave to it, followed by chlorhexidine 2%, and then calcium hydroxide applied similarly to the vital case. We confirm calcium hydroxide placement always with a radiographic image. Unintentional extrusion of small amounts of calcium hydroxide is common in non-vital cases, sometimes through the draining sinus. This shouldn't be of concern, and the material is readily resorbed with time. Remember, when we do the right thing, our patients get better, but so do we. Thank you for listening and joining me again when we take another trip beyond the Terminus. See you then.